Welcome to our fourth and last lecture series on development and congenital malformations of the central nervous system. In this particular fourth lecture, we are going to look at congenital malformations of the brain, as well as those ones of the ventricular system. Just as a matter of orientation, I chose to divide the lecture series on development of the nervous system into 4 parts for the sake of easy delivery. In the first part, we looked at neurulation and neurotube disorders. In the second part, we looked at development of the spinal cord as well as spinal dystrophic disorders. In the third part, we looked at development of the brain and the ventricular system. So those 3 we have already done, and the recording links are as shown. If you've not had a chance to listen to 1 or 2 of them and you want to do that, maybe it's okay you can just check that first before we look at this last part, because largely this last part builds on the previous one, and especially on the third lecture. So in this particular lecture, we'll be looking at congenital malformations of the brain, as well as those ones of the ventricular system. Maybe just to remind you about something that has been a theme that we built on the previous 3 lectures, but still important to highlight on it on this particular lecture, because the approach I'm going to take will be based on this theme, that the human central nervous system can be described to develop in 4 phases based on the events that take place rather than based on sequence of events. The first event that I want to highlight is the phase of dorsal induction. The phase of dorsal induction involves the phase of formation of the neurotube. So basically, when you talk of the phase of dorsal induction, we are referring to the period of neurulation. And remember, we have primary neurulation and secondary neurulation. But as with regard to formation of the brain, the primary neurotube is the one that applies. The secondary neurotube only applies to formation of the caudal end of the spinal cord. Now that in this particular lecture, we are going to look at malformations of the brain. So largely, when you talk of dorsal induction, we are referring to primary neurulation. After primary neurulation, there is a phase of ventral induction. The phase of ventral induction is largely the phase where the rostral neurotube is induced to form the brain vesicles, which then undergo separation to form the right and the left hemisphere. And that will be largely referring to the prosencephalon being patterned to give you telencephalon and dencephalon. Well, ventral induction is not limited to the forebrain only. We also see the influence of ventral induction on the midbrain as well as the hindbrain, but it's largely for cleavage of the forebrain. After that, we have a phase we are calling the phase of neuronal proliferation and migration. What occurs in this phase? This is the phase when neurons increase in number. Is a period of neurogenesis. And when neurons increase in number, something else also happens. The neurons migrate from deeper zones to peripheral zones. What's the aim of this migration? The aim of this migration is so that we see that we form the cerebral cortex. So basically, neuronal proliferation and migration is a process of cortical development. It's a process of development of the cerebral cortex. And we saw in previous lectures that there are multiple waves of migrations of neurons, and that the earlier migratory waves take deeper zones of the cortical plate, and later migratory waves take superficial zones of the cerebral cortex. Lastly, we have a phase of neuronal myelination, where we now form myelin sheath around axons of neurons in the nervous system. So these are the 4 phases of development of the CNS. I'll be basing my discussion of malformations of the CNS based on those 4 phases, and that is why I chose to first highlight on them. Now, congenital malformations of the central nervous system are really many. We are not able to discuss all of them in a single lecture. However, they have been classified, and there are different ways of classifying congenital malformations of the central nervous system. There are different ways in which the malformations have been classified. However, one of the classification is based on the presumed dominant defect. And I'm using these words intentionally. Presumed here would then mean that perhaps not even confirmed that this is the actual defect, or the actual dominant defect. Just presume that this is the main thing. Understand it this way. You may have a syndromic lesion of the brain. So multiple parts of the brain are affected in that case. But out of those multiple, which one is a dominant defect? So this classification is based on that dominant defect. And I think I'll be grouping them based on that, and especially based on how they occurred according to the 4 phases that we talked about. Now that I've told you that there are several malformations of the central nervous system, which malformations am I going to talk about in this particular lecture? I've chosen to give priority to those malformations which are anatomically distinctive. You see one and it gives you a moment of stare, like, wow, what's that? They're anatomically distinctive. I've also chosen to give priority to those malformations which you are likely to come across in clinical practice more often. So they are seen most of the time. And lastly, I've chosen to give priority to those malformations that have profound impact on early childhood development, including perhaps not being compatible with life. So these are the ones that I'll highlight largely. That does not mean that these will be the only ones. But for the sake of understanding, I think this is what I think is more practical to approach. Okay, so what's our learning outcome? I'll discuss the malformations based on the phases of development. So we look at disorders of dorsal induction. The disorders of dorsal induction are basically disorders related to the formation of the neural tube. And so we call them neural tube defects. We have already partly done neural tube defects. In our first lecture on neurulation and neural tube defects, we captured them. I'll just repeat on them because now these are separate lecture. And also, I want you to understand all of them as a concept, and that's why I'll still highlight on them. But remember, neural tube defects can either be cranial defects or spinal defects. The spinal defects are the ones we call the spinal dystrophic disorders. Considering that this lecture is focusing on malformations of the brain, so I'll only focus on cranial neurotube defects. I will not focus on spinodystrophic disorders. Those ones we've already covered adequately in our second lecture, where we looked at developing the spinal cord and spinodystrophic disorders. The other thing we are going to look at are disorders of ventral induction. Disorders of ventral inductions are disorders of forebrain cleavage, separation of the forebrain into right and left. They are disorders of cleavage of the forebrain, and we'll be looking at them. We'll also look at disorders of cortical development. Disorders of cortical development are disorders of neuronal proliferation, migration, and cortical organization. So we'll see which disorders fall under that category. We will not look at disorders of neuronal myelination in this particular lecture, because most of these are not distinctively anatomical. They'll be more functional disorders. So yes, they have clinical impact. There are many, and they have a lot of clinical impact. But from an anatomical point of view, from gross anatomy point of view, there may be not much to say about them. And that's why I've chosen not to talk about them. That does not mean that they're not important. You'll actually come across many of them, things like, there are quite a lot. There are disorders of myelin itself protein. Then there are those demyelinating diseases like multiple sclerosis and the like, but we'll not talk about them. However, there's an entity that we'll talk about in this lecture, which we call posterior fossa malformations. These are malformations that affect the brainstem and the cerebellum, essentially pons, medulla, and cerebellum, including the fourth ventricle. Lastly, we'll just highlight on disorders of the ventricular system. Now, that will just be a highlight because many of these anomalies also affect the ventricular system. But I'll say something about unique anomalies of the ventricular system as well. Let's start with disorders of dorsal induction, which are disorders of neurotube development. So we call them neurotube disorders. So disorders of dorsal development are disorders of closure of the neurotube. They occur as a result of defective closure of the neurotube. There are quite a number, and let me highlight from them. The first one shown in this image is what we call anencephaly. Anencephaly occur as a result of complete failure of closure of the cranioneuropole. Remember, the cranioneuropole is meant to close at around day 24, day 25, 2 to 3 days earlier than the caudoneuropole. So if the cranioneuropole fails to close, the forebrain itself will not develop. The term anencephaly would mean that the whole brain is not there, but that's not usually the story. In most cases, there's actually a brainstem. However, the forebrain itself is not there. Cerebellum may also be there, but at least the forebrain itself is absent. That is anencephaly. Anencephaly is not compatible with postnatal life, as you'd imagine. So these are MRI images of a case of anencephaly. And you can see that, yes, the brain is lacking, the forebrain is lacking. There's a brainstem, as you can see there. Even in this one, T2 MRI, there's a brainstem, but the forebrain we're not seeing. And because there's no brain, even the skull is now not there in this particular one. So there's also a crania in this malformation. Closely related to that is Kefalo cells. Kefalo cells are less severe disorders of neurotube closure. So in Kefalo cells, there's just a small portion that did not close. It's not the whole cranial neuropole that did not close, but maybe just a small part that had a problem with closure. So if you compare them with anencephaly, Kefalo cells are less severe, and so they are actually compatible with the postnatal life. They are characterized by protrusions of either meninges with CSF, of course, or brain tissue through a congenital defect, which is involving the skull and dura mater. So understand that. You see, in an anencephaly, the whole neurocranium was absent. In this one, the skull is present, but there's a small part of the skull that has a defect. And then associated that small part of the skull that has a defect, there's also a defect in the dura mater in that part. So what happened? The other meninges protrude. So arachnoid will protrude through that. Or sometime it will be meninges together with brain tissue protruding through that particular defect. We give them names depending on what has gone through. So we use the term meningocele if the protrusion contains meninges with CSF. We use the term enkephalocele if the protrusion also contains brain tissue. Those are Kefalo cells. These are examples of Kefalo cells. You can further classify them based on where they are found. Like in this one, it's on the occipital region. So you call it occipital Kefalo cell. Based on the size, this is most likely also having brain tissue perhaps, and so it's most likely an occipital enkephalocele cell. But that will require imaging to confirm that actually there's brain tissue inside. This one, it's on the frontonasal aspect. So this is frontonasal cephalocele. Again, it could be enkephalocele or it could be meningocele. Most of them are cephaloceles. Encephaloceles, as we can see here, like this one, we can see, yes, there's a pocket of CSF, but there's also brain tissue protruding. So this is enkephalocele, frontonasal enkephalocele. This is occipital enkephalocele. We can see there's a pocket there with fluid inside. Then there's some brain tissue protruding as well through the defect. Similar to that one as well, occipital enkephalocele. How about this one? This is the same as that, except that this is T1 MRI and that's T2 MRI. So here fluid is dark, here fluid is bright. We see a protrusion through the base of skull. If you orient yourself well, look at that, that's a brainstem. So this is the basilar bone, which is the same as there. And so the way this defect is the level of the sphenoid. So this is sphenoidal cephalocele. Let's try to see if we can see brain tissue inside it, and we don't see brain tissue inside it. So this is a sphenoidal meningocele. It's a meningocele, there are no brain tissue inside. Right, those are cephaloceles. The other disorder of dorsal induction is this one that we call Cary2 malformation. You may call it anal Cary malformation. Now I'm calling Cary2 because there are many Cary malformations, Cary1, 2, 3, 4. Well, the classification is a bit also varied, but there's conventional agreement on Carry1 and Cary2. Cary2 malformation is the one related to dorsal induction, and that's the one that is considered part of a neurotube defect. Carry1, we are going to discuss it under another subheading. So what's a Cary2 malformation? Cary2 malformations are intracranial manifestations of posterior dystrophic defects. I want you to understand that. We are saying that there is most likely a dystrophic disorder in the spinal cord. So there's some spinal dystrophic disorder. Maybe it's a meningocele, myelomeningocele, and the like. And because of that, the spinal cord is somehow held down so that the spinal cord may not be very free to move upwards the way it usually does. Remember, the vertebral column outgrow the spinal cord. So as development continues, the spinal cord usually shortens, in quotes. If there is a myelomeningocele, it means that that part of the spinal cord would be relatively fixed to that region of malformation. Such a spinal cord may therefore not be free to be hanging upwards as the normal spinal cord would do. So because of fixing of the spinal cord lower part, there would be some pull effect on the cranium. So Cary2 malformations represent a constellation of malformations which are due to that kind of mechanism. They are intracranial manifestations of the dystrophic disorders. So how will this manifest? It's a range of brain malformations. It's not just one thing, but a range of brain malformations. Several things are affected. However, the hallmark of Cary2 malformation is largely within the posterior cranial fossa. That much of the manifestations are seen on the posterior cranial fossa. So what are some of these manifestations? This image tries to capture some of the malformations, some of the manifestations that I want you to pick on Cary2 anomaly. Look at the position of the foramen magnum. So this is the basilar bone up to that end. That's the occipital bone up to there. So from there to there is foramen magnum. That means that this is C1 atlas and that is C2 axis. What do we notice? We notice that the brainstem has been pulled significantly downwards through the foramen magnum. So we have herniation of the brainstem into the cervical column. It's not just the brainstem, it's also involving the cerebellum. The lower part of the cerebellum is also pulled down, as we can see. Look at the shape of the fourth ventricle in therefore with that regard. It's slit-like and it's also pulled downwards, it's been tracted. Look at the shape and the length of the medulla oblongata. Again, there's some manifestations. Concept is that the posterior fossa structures are pulled downwards through the foramen magnum. We have downward herniation of the posterior fossa structures. That is one of the hallmark, main hallmark. But maybe let's look at some of them, even from this particular MRI images. Let's look at the first one. So we see that the tonsils of the cerebellum have been pulled down in this particular image. We can capture that well there. The fourth ventricle is slit-like. Look at that one, same story. The posterior fossa structures have been pulled down. And so the brainstem appears really elongated. But there are also some manifestations on the midbrain, like the beaking of the tectum there. Look at this third image and look at the corpus callosum. There's some abnormality on the corpus callosum. Remember, I told you that it's a spectrum of malformations, really, several malformations, although most of them are seen in the posterior cranial fossa. Importantly, downward herniation of the posterior fossa structures. That means that the brainstem, fourth ventricle, and cerebellum. But there are other anomalies, as we can see. That is Cary2 anomaly, which can also be called anal Cary. And that summarizes for us the disorders of dorsal induction, neurotube disorders on the cranial side, so the cranial neurotube defects. Now let's look at disorders of ventral induction. As we said earlier, disorders of ventral inductions are disorders of cleavage of the forebrain. So there'll be problem with the separation of the right and the left hemisphere. We can start with one that we call Colossal Dysgenesis. As the name suggests, Colossal Dysgenesis means that there's a problem with the formation of the corpus callosum. It could be complete or partial malformation of the corpus callosum. How can it be malformed? Maybe it's just too small. So it could be hypoplastic, very tiny. It could be truncated, which means that one side is present, then the other side is not there. It's been cut off. So maybe the anterior part is present, the posterior part is absent, or vice versa. Or it may have a focal segmental defect. To mean yes, the anterior and the posterior parts are there, but somewhere in the middle, there's a section that is not there. All this, remember, corpus callosum joins right and left hemisphere. So callosal dysgenesis is basically a disorder of separation of the forebrain. There are some extreme cases where the corpus callosum may be completely absent. If the corpus callosum is completely absent, we call that callosal agenesis. Now, we don't necessarily use the term callosal dysgenesis, but is a term callosal agenesis. Generally, callosal agenesis may be an isolated anomaly, to mean that could be the only malformation we are seeing in that particular brain. But a number of times, again, it's just part of an association of a malformation. For example, callosal agenesis may be part of Cary2 malformation, as you've seen. Look at these MRI images. The first one shows us a very tiny corpus callosum on the anterior aspect. So that would go for hypoplasia and truncation as well. This one, we are not seeing the corpus callosum in that particular region, but we cannot really confirm whether it's completely absent or segmental because there's a coronal view. Similar to that one, we are not seeing the bridging of the corpus callosum. So it's definitely dysgenetic. We don't know whether it's complete agenesis, again, because this is a coronal view. You need a sagittal view like that and that to tell whether the corpus callosum is completely absent or it's just dysgenetic. Look at this one. So this is the journey of corpus callosum. That's the body of corpus callosum. And this is the splenium of corpus callosum. We see a defect there. So this will go for focal segmental defect of the corpus callosum. How about this one? Largely present in most of its parts, but the size look really small. So that will go for hypoplasia. This one, the posterior parts are present, splenium and the body. We don't see the anterior body and the genio, even the rostrum. So this will go for truncation. Similar to that, that will go for truncation, and this one will go for focal segmental defect. Apart from callosal dysgenesis or agenesis, another disorder of ventral induction that I want to talk about is what we call holoprocencephaly. This one is a spectrum of malformation as well. The holoprocencephaly spectrum involve abnormal separation or fusion of the median and paramedian brain structures. Think about that in an understanding way. What are the median structures? Thalamus, hypothalamus, perhaps. What are the paramedian structures? Basal ganglia and the like. The medial aspects of the hemispheres are still median structures like the paracentral lobule and the like. So we are saying in holoprocencephaly, there is abnormal separation or abnormal fusion. You know, if it's abnormally separated, then maybe it's also abnormally fused. So I want you to understand them together. We are largely focusing on the forebrain, although it may affect the other parts of the brain as well. In holoprocencephaly, the ventral forebrain is the one that's affected more, which means the sides of the frontal lobe, it's affected more, but the severity decreases as you go posteriorly towards the occipital lobe. That is one hallmark. The other hallmark is that the medial structures are affected more, and the severity again decline as you go laterally. So things like thalami may be affected more, but things like insular cortices may be less affected because they're more lateral. What do we check when we want to pick holoprocencephaly? We check the separation of the forebrain. Is it completely separated? The right and the left hemisphere, are they completely separated? Or there's some places where the right and the left hemisphere are abnormally fused. So we look at that one. And usually there is incomplete separation of the forebrain. In those malformations, again, there'll be absence of the anterior interhemispheric falx. Remember, this is the falx cerebri, the fold of the dura mater that separate the right and the left hemisphere. The falx cerebri runs in the median longitudinal fissure. So in holoprocencephaly, that may be absent. And essentially look at the anterior aspect of that fissure. You know, the posterior aspect may be present, fine. But is the anterior aspect also present? Now that I've told you that the severity is more on the anterior aspect, so we look at the anterior aspect. Is the falx formed to separate the right and the left frontal lobe? So these malformations may have absence of the anterior interhemispheric falx, which means absence of the anterior part of the falx cerebri. Lastly, they may have fusion of the central gray nuclei. The central gray nucleus here refers to the encephalon, and let's keep it simple, thalamus. So are the two thalami fused or well separated? So in holoprocencephaly, the right and the left thalamic nuclei are fused. We have fusion of thalami. Capture those in this particular MRI images. So in this first one, we see that there's no separation between the right and the left hemisphere. In the second one, we see partial separation there. In this third one, we may not capture that much, but there's an abnormality here associated in some parts of the corpus callosum that are not well formed. And in this coronal view, we see fusion of the midline, the central nuclei, thalamic fusion, right and left. This first one is called a lobar holoprocencephaly. The second one is called semilobar holoprocencephaly. And these last ones are called lobar holoprocencephaly. So that is in decreasing severity. In a lobar holoprocencephaly, there's no lobe at all. In semilobar, there are some lobes which are formed, not complete. In lobar holoprocencephaly, the lobes are there, but the midline structures are fused. So that is holoprocencephaly spectrum. Closely related to holoprocencephaly spectrum is what we call syntelencephaly. Syntelencephaly is also called the middle frontal variant. The main issue with this anomaly is that, yes, there are separation of the frontal and occipital aspects of the forebrain. However, the parietal region of the forebrain is the one that is fused. So the parietal regions, there's an abnormal fusion. It's a variant of holoprocencephaly. We call it middle frontal variant. Also related to holoprocencephaly, a less severe form of the spectrum, sometimes we consider it so, is what we call septo-optic dysplasia. In septo-optic dysplasia, the abnormality is on the septum pellucidum, which is lacking, and there is hypoplasia of the optic tract pathway, the optic nerve optic tract pathway. There's also hypoplasia of that pathway. So we call that one septo-optic dysplasia. Remember, these are midline structures. So in this one, the lobes are okay, but now the problem is with the septum pellucidum and the optic nerve pathway. Septo-optic dysplasia may, however, have multiple associations: neurotube defect, disorders of neuronal migration, schizencephaly. I'll show you what schizencephaly is shortly. So there could be other multiple associations, so that may not be a distinct anomaly of its own. So just something that I wanted to also mention, it escaped my mind when we're talking about holoprocencephaly spectrum, is that in holoprocencephaly, there would also be facial manifestations of the same. And depending on how severe the holoprocencephaly is, there would be some facial manifestations. For example, a child with a lobar holoprocencephaly may also be just having one eye instead of two. Or there's a way the facial structures are also appearing abnormally fused because of the same thing that's occurring in the brain. The other disorder of ventral induction that I want to talk about is microcephaly. As the name suggests, microcephaly simply means that the head is smaller because the brain is small. The head circumference is smaller than the normal by more than 3 standard deviations. Microcephaly may be caused by a number of causes, including prenatal infections or some prenatal insults that affect blood supply to the brain. It may also be just part of a particular syndrome as well. So this image shows images of children with microcephaly. You appreciate that the head look relatively small, and that is because the brain is small. And we are focusing on the neurocranium, not the whole head. So the neurocranium is disproportionately smaller than normal. Another anomaly that I want to talk about is hydrancephaly. This can easily be confused with hydrocephaly, but they're different. Hydrancephaly is where we have near complete to total absence of the telencephalon, that is cerebral hemisphere. So you can imagine the whole of the cerebral hemisphere is near absent or totally absent, but we have relative preservation of the brainstem and central gray nuclei, as well as the cerebellum. Those ones are intact. So the pons, midbrain, medulla oblongata are there. Thalami are there. The cerebellum is present, but the hemisphere is either very thin or not there at all. What's the major cause? The major cause is if you have intrauterine ischemic insult during that period of ventral induction. So the telencephalon degenerates. These images capture for us how hydranencephaly look like. We see just fluid space. Maybe this one's a good one. So look at that. This is midbrain, that is pons, that's medulla oblongata. This is the thalamus, that is cerebellum. That's the tentorium. So here we see just a small part of the occipital lobe, but the rest we don't see anything. It's just water, similar to that one. So this is hydranencephaly. Those are disorders of ventral induction, disorders of cleavage. Now we can talk about disorders of cortical development. These are disorders of neuronal migration, proliferation, and organization. I want to start with what we call lysencephaly. The term lysen means smooth, so smooth brain. Lysencephaly is marked by thickening and lamellation of cerebral cortex with no sulci. Look at that one. So the cortex is very thick and we don't see sulci. So the outer surface appears really smooth. Lysencephaly may be complete, like this one, or partial like this one. So this one, we see gyrification and sulcation on the anterior aspects, but they're lacking the posterior aspects. Look at that, the thickness of the cortex, they are very thick. And at a high magnification, you'd have seen it being lamellated, but importantly, we don't see sulcation. So this is partial lysencephaly, and this is most likely complete lysencephaly. Then we have microlysencephaly. So microlysencephaly is basically a problem caused by diffusely decreased neuronal proliferation. The neuronal proliferation is diffusely decreased. So here we are combining the size of the brain as well as the gyrification. So the brain will be smaller, micro, and the gyrification is also not okay. You see in the previous one, the overall size of the brain was okay. But here the brain size is reduced and there's also less of the sulcation. So we call it microlysencephaly. In this one, the brain, the cortex will be, or rather the brain mantle is relatively thinned out as opposed to being thickened. The mantle of the brain is thinned out because of a problem with proliferation. Then there is agyria. Agyria means that there's no gyri, and pachygyria means that the gyri are fewer. So either there are no gyri or there are fewer gyrification. So like in this case, this would be more of a pachygyria. We can see gyrification there, but few. So it's characterized by thinning of the cerebral mantle and agyria, pachygyria pattern. The overall size of the brain is small. We also have this one that we call hemimegalcephaly. Hemimegalcephaly, as the name suggests, hemi means half, mega means big. So one half of the hemisphere is abnormally enlarged. As you can see in this particular image where that right side is enlarged. This is the right side of the patient, that's the left side of the patient. So the right side is enlarged, the left side is normal. In this one, the right side is enlarged, the left side is normal. And we can see it's also shown in the ventricular spaces as well. So this one results from overgrowth of one of the hemisphere or one of the lobe of the hemisphere, this overgrowth. The hallmark is asymmetric enlargement of the brain, including its ventricle. So when you have asymmetric enlargement of a ventricle, you start thinking of hemimegalcephaly. Remember, enlargement of a ventricle would be called hydrocephaly. So you need to understand when you have ventriculomegaly, what is the context of that ventriculomegaly? Another disorder of cortical development is what we call Graymata Heterotopia. Graymata Heterotopia refers to presence of ectopic gray matter, ectopic cortical tissue within the white matter. We expect cortical tissue to be in the periphery when neurons migrate from deeper zones to more peripheral zones. So we expect cortical tissue to be here in the periphery. However, in Graymata Heterotopia, we have multifocal or band presence of gray matter in deeper structures. For example, in this second image, we see a band of gray matter in the white matter. So this is band gray matter heterotopia. In this other one, we see gray matter just next to the ependymal lining there, like that one, or even that one. So this is still gray matter heterotopia. These are multifocal, could just be focal, multifocal, or band gray matter heterotopia. Another disorder of cortical development that I want to talk about is what we call focal cortical dysplasia. Now, this occurs as a result of abnormal development of a particular focal region of the cortex, so that the neurons in that particular way in that particular site are abnormally organized. So it appears as a focal thickening of the cortex. This might be a bit hard to pick if you're not a radiologist, but yeah, those regions pointed there represents regions that are of focal cortical dysplasia. In this particular region, we do not have the normal cortical lamellation. You know, the 6-layered cortex, we have those 6 histological layers. So in those particular regions, we don't have that normal layering. These children usually also present with seizure disorders. Another one, which we call Polymicrogyra, PMG. As the name suggests, in Polymicrogyra, we have excessive convolutions of the cerebral cortex. And usually these convolutions are tiny. So polymicrogyra, excessive tiny convolutions of the cerebral cortex. However, there's some regions where the cortex appears really thickened, like in that region pointed there. And in those regions of thickening, there's some significant level of irregularity. That is PMG. Schizencephaly can also be considered as a disorder of cortical development, although it's also a disorder of the ventricular system. Why do we call it a disorder of cortical development? Because in schizencephaly, there's a cleft within the cerebral hemisphere. Therefore, there's a cleft cutting across the cortex. This cleft extends from the pile surface to the ventricular space. As you can see here, the bright one is fluid. And so this is the ventricular space. And on the left side of this particular patient, the left lateral ventricle is continuous with the subarachnoid space through that large cleft. Even this one, there's a large cleft connecting the subarachnoid space with the right lateral ventricle. Usually, the cleft will be lined by this plastic gray matter. So that's why it's also part of disorders of cortical development. Good. Now let's talk about malformations which affect the brainstem and cerebellum. Let's just call them posterior fossa malformations. We'll start with what we call Dandy-Walker malformation. Dandy-Walker malformation consists of three things. One, there is complete or partial agenesis of the cerebellar vermis. As you can see in this image, the cerebellar vermis is very tiny. So it may be tiny like that, or maybe completely not present. Another component of this syndrome is that we have cystic dilatation of the fourth ventricle. So the fourth ventricle is enlarged, cystic dilatation of the fourth ventricle. And lastly, we have enlarged posterior fossa with cranial displacement of the tocula. This is the tocula. The tocula is the point of fusion of the falx cerebri with the tentorium cerebelli, or you can look at it in terms of the vena sinuses, superior sagittal sinus, and the straight sinus coming to meet there. At the level of the tentorium, that's the tocula. So we'd expect the tocula to be somewhere here. But now we see it displaced upwards, which means that now the posterior fossa is abnormally enlarged. There's enlargement of the posterior fossa. There is dysgenesis or agenesis of cerebellar vermis, and there is cystic dilatation of the fourth ventricle. That constitutes Dandy-Walker malformation. These images show us images of Dandy-Walker malformation. So in this particular first one, T1 weighted, fluid is dark. We see a large cystic dilatation of the fourth ventricle, upward displacement of the tocula, and cerebellar vermis, which is hypoplastic and maybe upwardly displaced, similar to what you see in this third image as well, in the fourth image. This other one, we actually not seeing the vermis completely. We don't see it, at least the level we're not seeing it. And there is that particular communication between the fourth ventricle and this space, similar to that or that one. Apart from Dandy-Walker malformation, we also have what we call megacystana magna. Megacystana magna can be easily confused with Dandy-Walker malformation that we've just seen, but there's some important difference between the two. The key difference between Dandy-Walker malformation and megacystana magna is the cerebellar vermis. In this malformation, megacystana magna, cerebellar vermis is intact. In the previous one, the cerebellar vermis was hypoplastic or absent. And that's the major difference between the two. Okay, another anomaly of posterior fossa is Cary1 malformation. Cary1 malformation is a malformation manifested by downward displacement of the cerebellar tonsils. So the cerebellar tonsils are downward displaced through foramen magnum, and it is not associated with a defective neurotube closure. Remember, in Cary2, the posterior fossa structures were herniating through foramen magnum, and there was associated dystrophic disorder. In Carry1 malformation, we have displacement, we have posterior fossa herniation into the foramen magnum, which means that part of cerebellum and brainstem herniate through foramen magnum into the spinal canal. But in this one, we don't have a dystrophic disorder. So that one is called Cary1 malformation. So when you look at it, the tonsils will be going down. Part of the brainstem is also going down. This downward displacement of the tonsil causes disruption of the CSF as it flows through foramen magnum. And this usually predisposes to formation of syrinx within the spinal cord. So Cary1 malformation is associated with syringomelia for that particular reason. So these images show you images of Cary1 malformation. What we check is displacement of the cerebellar tonsils and possible presence of syrinx within the spinal cord. As you can see in all those images, these are syrinx there, that one, that one, that, and that large one. And in all of them, downward displacement of the cerebellar tonsils or the brainstem, as you can appreciate. Maybe in this one, that one may not be nice for the cerebellar tonsil, but at least we can capture the one for the brainstem. This one is captured, even that one. That line shows you the level of the foramen magnum. There's some part of the cerebellum going down, and that one is also clearer. This is the level of foramen magnum. We can see the tonsil going down and part of the medulla oblongata. Another anomaly of the posterior fossa is what we call rhombenkefalo synapses. A long name, but understand rhombenkephalon, that is hindbrain, then synapses, which means fusion. Rhombenkefalo synapses is a term given to congenital absence of the cerebellar vermis. And because of that absence of the cerebellar vermis, the right and the left cerebellar hemispheres are fused, as you can see in that particular image. You see, this is a bit different from where the vermis is not there and the two hemispheres are not fused. So in this one, the vermis is absent, right and left hemisphere are fused. We call that rhombenkefalo synapses. These are still images of rhombenkefalo synapses. The last spectrum of malformation that I want to finish with are disorders of the ventricular system. We are most likely already aware of disorders of ventricular system. The term hydrocephaly is what we use to refer to increased amount of CSF within the ventricular spaces, so the ventricular spaces are enlarged. So these three babies show you babies with hydrocephaly. So hydrocephaly is enlargement of the ventricles, and enlargement of the ventricles could be caused by multiple things. Congenitally, they're largely due to obstruction of flow, either in various places like in the cerebral aqueduct, or basically in the foramen of Monro. And so this shows you hydrocephaly. This one shows you a particular type of hydrocephaly where the posterior horns are the ones which are predominantly enlarged, and the anterior horns are not as enlarged as the posterior horns. So we have asymmetric or relative sparing of the anterior horns, and the posterior horns are predominantly enlarged. We call that colpocephaly. And then in this one, we'd already talked about where there is a cleft connecting the ventricle to the subarachnoid space. We classified under disorders of cortical development. It's also a disorder of the ventricular system. Great. So that marks the end of the lecture series we've been having on development of the central nervous system. Remember, this was just one of the 4. Either way, we've looked at now 4 lectures on development of the central nervous system. First one, neurulation and neurotube disorders. We looked at that. Second one, development of the spinal cord and spinal dystrophic disorders. The third one was development of the brain and ventricular system. And this last one, where we looked at congenital anomalies of the brain. So that marks the end of our lecture series on neurodevelopment. I hope you've now understood the development and congenital malformations of the central nervous system. Thank you very much. We'll stop there.